All right. Well, hello, everyone. Thank you so much for joining us for this breakout session entitled, as I'm sure you all know, Ethical Dilemmas in Complex Discharge Planning. My name is Melissa McGuire, and I am a social worker. I've been a social worker for about, 25, 30 years now. I'm currently a social work manager at Asante Rogue Regional Medical Center and co-chair of the ethics committee there with Asante. And I am incredibly happy to be joining you all today. Thank you for being here.
And
I will
hi,
hand off to my yes, Melanie.
Thanks, Melissa. I'm Melanie Smith. I am currently a supervisory social worker at the VA in their homeless programs. But before that, I was a supervisor of social work at a local hospital where my focus was on complex discharge planning, specifically through partnerships and collaboration with area agencies and like community partnerships that we developed. And now I hope to house homeless veterans so that they have places to go when they leave the hospital, your places. Did I see a hand that was raised? Somebody have a question? Okay.
I was going to say this is an eager group. There's already a hand being raised.
I love it.
All right. Couple of things. So I think I safely speak for both Melanie and myself that we have no disclosures that we need to share today. And I will just take a moment real quickly to go over the objectives. One thing I am going to give everyone a heads up about is that you all were given a copy of the slide deck that was associated with the meeting invite today. And we do want to acknowledge that there were some technical complications related to slide decks and so forth. So the version you have is slightly different than the version we'll be presenting today. But yes, so please give us grace with that, and our apologies in advance for any little confusion that might create. So our objectives today, we're just going to start out with doing a real brief review with the core principles of biomedical ethics. We're going to pick your all's brain as far as request some information about standards of practice, institutional culture, societal values and norms, as well as resource issues that contribute to ethical dilemmas and complex discharge planning. So we will share some of our own thoughts about that, and then also invite you all to share with us some of your thoughts. And then, as you all heard in the previous session, we're going to be reviewing a case, the case of Gary, a patient with autism. And what we're going to do is, after doing our reviews and examinations, we're actually going to break you all into breakout groups of about 10 or 12. And we are going to invite you to approach this case as though you were the ethics committee that were being asked to make recommendations to the treatment team. So as we're having these conversations to lead up to that point, just keep in mind that that's what we will be asking of you. And of course, we'll remind that of you again as we get to that point. So yeah, that's just a little bit of an overview. Next slide. All right, so just real briefly, I know I'm probably very much preaching to the choir here as far as why biomedical ethics are important. But I think it still bears mentioning that it is crucial when it comes to optimizing, integrity, trust. It is imperative when it comes to conflict resolution, not only between staff members, between families, patients, and staff members. It also enormously improves our efficacy, our efficiency. Involving an ethics consultant or a committee in complex cases can significantly reduce legal liability and improve overall professional satisfaction. So, the next slide, please. All right, and then just a real brief review. We've heard these words mentioned multiple times today. These are the basic principles of biomedical ethics as developed by Childress and Beauchamp many years ago, autonomy, non-maleficence, beneficence, and justice. Next slide. Just a brief review. Autonomy, I think most of us who have been in healthcare for a while recognize the importance and how critically important autonomy is, in that it allows folks, personal rule of the self, free from both controlling influences, interferences from others, from personal limitations that prevent meaningful choice, such as adequate understanding. Next slide. The physician's guiding maxim, and I think safe to say probably the guiding maximum for most medical professionals, non-maleficence refers to first do no harm, and of course references our obligation to not intentionally, knowingly inflict any harm on folks. Next slide. And then the opposite end of that, beneficence. It, discusses, it involves the moral obligation we have to take positive, direct steps and action to help others. Next slide. And justice, which I think we've become increasingly aware of in this recent half decade. And I think that was one of the incredible, looking at COVID, I think it's, sometimes can be difficult to see there having been benefits to COVID, but I would say one of the benefits that if I'm taking it from a glass half full perspective, that I think issues related to justice and equity, I'll speak for myself, I think have become so much more clear. The importance of it and how critical justice is has become so much clearer, particularly since the onset of the COVID pandemic. All right, next slide. And then finally, just some other little pieces to keep in mind, particularly as you are reviewing this case and you are having your group discussion and coming up with recommendations for a medical team, is to think about it through the lens of compassion, discernment, trustworthiness, integrity, and conscientiousness. Next
Thanks,
slide.
Melissa. Yeah, so I'm going to move into talking a little bit about standards of practice and institutional cultures, and really thinking about, as we move into the next few slides, about structural barriers that contribute to some of the complexities in discharge planning. Earlier, we learned about or heard and revisited social determinants of health. I think you can see some of the ties in what we're going to be talking about in these next few slides to what that presenter spoke about. And I'd kind of like to ask y'all if you want to take yourselves off mute or if you want to type in the chat, when you think about standards of practice in our organizations or in your organizations and institutional cultures in healthcare, what might you imagine would be barriers to getting somebody moved through the continuum to getting them discharged, or how might these standards of practice and institutional cultures, how might they contribute to some of the barriers of getting those folks moved through?
And I would add to that, ethical issues you all have experienced yourself when it comes to complex discharge issues, but also when you think about this case, given the fact that it has already been introduced to you briefly, any institutional cultures or standards of practice you would imagine might create barriers and ethical challenges. So I see here in the chat, one, inadequate resources in the community.
Yep.
Yep.
That covers quite a few things, actually. Yes, absolutely. Lack of mental health care resources, hierarchical nature of medical system. Thanks, Christy. That's great. Facilities refusing to accept for behaviors. Yep. So some of the things that regarding, yep, that's one of my favorites is medical necessity. Yep. Insurance coverage. Great. Thanks. Thanks, Lori. Some of the things that we came up with, like we are seeing, and you all are probably seeing, that social admits are increasingly common. We will often have folks that maybe meet marginal criteria for medical necessity, and they're brought to the emergency department, or they bring themselves to the emergency department. And There is sometimes a rub between the ED providers and maybe the hospitalists about who goes upstairs and who stays in the ED. We have the expectation that when people meet medical necessity, or when they're medically stable, I'll put that in quotes, that they are able to discharge, and administration and insurance gets very fussy when that doesn't happen. And then we have, one of the things that we've been discussing in several of these conferences is medical surrogacy and who gets to make decisions for folks who are deemed to be incapacitated. The idea that we assume that patients will choose safe discharge plans or adequately safe discharge plans. Yep, thanks, Camille. The past trauma in the same setting. If you've experienced trauma in a hospital or skilled nursing facility, or even through home health coming in to visit with you, you may refuse any of that, and then you become a non-compliant patient, which we all, I know we all have various connections to that word, but that gets thrown about a lot. That we have some paternalism in a medical setting, that we all know what's best, and that if patients refuse to do what we want them to do, then we get fussy ourselves about that. And that's when we talk about removing rights and getting guardianship. It's another standard of practice that I've seen. We also like to bring in APS. If they're not doing what we think is best, then we like to call on APS and tell them that they need to be watched now. Melissa, did you want to talk about these?
Okay. Yes. So shifting from the institutional cultures and standards of practice, we want to take a moment now and look more at societal values and cultural norms. So similar to the, as we asked before, could some of you all tell me, when it comes to complex discharges that involve ethical issues, what are some of the societal values and cultural norms you have seen come into play when it comes to those particularly challenging cases that you've dealt with? And feel free to either raise your hand if you'd like to tell us in person or live in real time, or in the chat, either way.
Criminalization of houselessness, yep.
Mm-hmm. Yeah, criminalization, stigmatization of the houseless. So some of the, yes, desire to be houseless.
Mm-hmm.
Yeah. A lot of responsibility that comes from being housed, that's for sure. Different kinds of responsibilities and challenges from being houseless. Yes, and stigmatization associated with substance use disorder.
The idea that you have to be abstinent and not, it's not a harm reduction model, but more of an abstinence model.
Yeah, so some that we came up with as well. Oh, and a couple more popping in here. Giving up on solutions or partial solutions. Kate, I'm wondering if you wouldn't mind, if I could put you on the spot, would you mind saying more about that?
You mean giving up on? So yeah, just in my experience now, I've been a little bit more removed from clinic. Is that you present patients with all these ideas and where they can do, what they can do with their health, and they say that's never going to work. I'm not going to do it. And so I was thinking of that with with the parents, or that it was never going to work. So
yeah.
So
rejecting the solutions that are being suggested.
The solution of that. So that's all I was trying to say, and not a very clear way.
Oh, well, I think you did a great job. Thank you. Yeah, that helped. So others y'all have come up with the belief that there is an adequate social safety net. Oh yes, don't get the social workers started on that. Social isolation and emphasis on independence combined with a lack of community care responsibility. Yes. American ethic of personal responsibility. Wow, you guys, when we go through the two pages, you guys have hit on just about everything we hit.
Yeah. Pull yourself up by your bootstraps.
Yep. Pull yourself up by your bootstraps. In fact, if you look at, that'll actually be on our second page. And I'm giving you all a heads up. I'm about to have a cat decide that he wants to be on camera. Let's see here. So yes, and what we had come up with, many of what you have already said. Can you? Societal norms regarding the responsibility or moral obligation to care for family members are changing. That was also something we had discussed. I think, lots of changes along those lines historically and over time. Treatment at all costs, the fact that we live in a society that often has a fear or an avoidance of end of life or death and dying. Aging populations and the expectations of healthcare and the demands it puts on healthcare. The expectation that surrogates will always act, should, and will always act in the patient's best interest and make decisions based on patient's instructions and wishes. Next slide. The assumption or belief that individuals will choose care plans that will best support their well-being, or family members will do that for their loved ones. That society will provide sufficient resources to vulnerable individuals. I think that's a value that doesn't always actually come to pass. That disabled individuals are best served in community versus institutional settings, and that patients can be discharged to a setting that can adequately meet their needs, and that kind of tapped into the fact that there will be sufficient resources for vulnerable individuals. Next slide. And then finally, these are the ones that I think many of you hit on. Actually so starting with autonomy and self-determination, obviously a societal value, a value being justice, sometimes in word, not always in action, that justice includes fair distribution of limited resources. And then, as you all mentioned, rugged individualism, the pull yourself up by your bootstraps value. And also, I think a cultural norm is that individuals are often held responsible for quote unquote non-compliant or non-treatment non-adherence.
To your access code or meeting number, follow.
Next slide.
That's it. I think we're on resource issues now, which some folks had already mentioned. When you think about healthcare, resources are quite an issue, because if everybody had big bags of money, as I like to tell some of my clients, then we wouldn't need to have a lot of these conversations. So I think some of you mentioned in the chat already some of the resource issues that we have in this country around our healthcare and how it can be a huge barrier to getting people discharged to the adequately safe discharge plan. And so I'm curious if there are other suggestions about resource issues that y'all might throw in the chat before we move on to the next couple slides. Yes, lack of natural supports, family to provide care. One thing that I see is lack of facilities on the other end that are able to provide the adequate supports for people that need them. Like if somebody has, facility level care, exactly, thanks Christy. Like if somebody has a broken leg and they also have a substance use disorder, well, maybe they don't want to detox from their substance use disorder, but they do need to get their leg treated. And so we often have big barriers about that around substance use, or lack of adequate mental health supports when folks, or cognitive supports when folks have other needs to go to either the hospital or to facility level of care. Anything else? Lack of lack of or poorly compensated caregivers are also untrustworthy caregivers. Yep. And that feeds into some distrust from our patients too, who maybe don't want to have anybody come into their home. So a couple of other things we came up with, shouldn't be a big shock to any of y'all, but you know, we have a real unequal distribution of material wealth in our country. It's the bigger gap is happening, and appropriate community resources are only available to people if you meet certain criteria, and either you have the big bag of money to pay for them privately, or you are very, very, very poor, and then the state is able to step in. But often there's folks in the middle that have to piece together care because of that. And then our favorite thing in the world, insurance, multi-payer healthcare systems. There's lots of folks that don't want to take this or that or the other thing because of the low reimbursement rates. Nobody wants to take Medicaid anymore because they don't get paid anything. It's a story that I'm sure is still being told in the discharge planning world. And that's just really impacting who gets seen. Yes, thank you. Oh, thank you. Rural settings. We're lucky in the Portland metro area that we have options, right? But I can't imagine for folks in a rural setting where you have maybe one option or a couple of options, or the other burden is that you have to travel outside of your area to go someplace else where you don't get to see family and friends because transportation may be a burden, right? So.
Yeah. And being in the Southern Oregon area, that is something that we experience enormously, the amount of folks with more complex needs that end up having to go to the Willamette Valley, Portland metro area.
So sometimes out of state, yep. So I just wanted to, with that, I want to be mindful of time and wanted to get y'all to your breakout sessions, but just to review the case study a little bit that we are presenting. I know they chatted about it briefly in the last session, but just wanted to talk about this case. This patient is Gary. We're going to ask you in a minute to break up into different rooms and chat as though you were the ethics team and that you are going to be making recommendations about how to move forward with this case with Gary. Gary is 17 years old. He is a very well-developed male child diagnosed with autism. At baseline, he's nonverbal, can communicate with some picture charts and sign, and can do some very basic ADLs, lives with his biological mother and father. Mother is the primary caregiver. Dad worked outside of the home, and mother did report locking him in his room when she couldn't control Gary's behavior. He presented to the emergency department multiple times over several weeks, one spring, and because of his particular needs, he had to be seen in the locked adult psych unit in the emergency department. He was examined and cleared by both medical and psychiatric providers in the emergency department because there were no medical needs that he had that they had found. And so we would send him back home. His family would care for him, and then he would come back home or come back to the emergency department the next week with similar concerns, just mostly behavioral disturbance in the home, acting out, and because of how large he could be dangerous to his mother and his brother, who also lived in the home. So he ended up being admitted. We tried to discharge him to his home with police escort, and his family refused to allow him to come into the home, and so he was sent back to the hospital. He would remain in the hospital for custodial care, spending most of his time in the emergency department, or needed to be medicated for his safety, the safety of the others, of the staff. We would engage with Developmental Disabilities Administration and DSHS in the state to work towards a safe resolution and a residential placement. The family would continue for multiple weeks to refuse to accept him at home. We were unable to have conversations without legal representation because the father had threatened a couple of the staff on the discharge planning team. And so it necessitated attorneys being with us during these calls and conversations. Twice weekly meetings were held to kind of talk about what the next steps might be. And just during this time, he ended up injuring over 30 frontline staff that were providing care to him in the hospital while he was admitted. And so that was a big consideration for us as we talked every week and met with all the players. So that's a very brief kind of description of the case. We wanted to pose some questions to you about what you might be thinking as you're working towards this, towards a resolution. What conversations, what kind of conversations might be had with all of you on the ethics team? How might you be communicating? What might be the most important things when you're working towards a resolution? Melissa, did you want to add?
No, I think that's it. I think the questions, I would imagine you all will be able to come up with plenty of your own questions, but also feel free to refer to the list that, if you want to help get the conversation started, refer to the list that we provided in the slide deck. And otherwise, I think we're about ready to break out, yes?
Yep, and so you'll go into your breakout. They said, thanks for that question, Camille. They said that he was in a safe space.
I guess that would be maybe something else to do. Does anyone have any quick questions before you go into your breakout rooms? Any clarifying questions?
And we'll be jumping in and out of the rooms too to answer any questions or to just check in. But yes, that was the response. They adamantly refused to get involved in the case.
I have a question.
Okay.
From a legal standpoint, this is a minor. I'm wondering what the parent's financial obligation is in a situation like this. I mean, are they being expected to pay the bill? Will they lose their house because of a hospital bill?
I would imagine it varies from organization to organization.
I can tell you that they were presented a bill.
Okay. All right, Samantha. So next step. I think Samantha, it's the next step for you to go ahead and have everyone set up in their breakout group.
Great. I have everyone set up and sending them there now.
Okay. I think we're going to give folks probably, sending them there now. Okay.
Oh, oh no, I'm sorry.
No, don't worry. I was just going to give them a general time frame, but that's totally fine. We can pop in and give that to them individually.
Okay, I actually too was just gonna jump in there and copy and paste the questions from the slide into each breakout because it won't transfer over to the breakout session. So I can put a timer, like let them know how long they have in there too, if that would be helpful at all.
That would be great.
Perfect.
Yes,
Thank
let's
you.
do that.
Okay.
Since
How
we're
long?
running a little behind, do we want to give them about 15 minutes? Do you think, Melanie?
Sure.
Okay, great. I will be popping in and out and copy and pasting all of this in there for them.
Thank you. All right, so presumably everyone's in their breakout sessions now?
They should be.
Folks.
Okay, great.
I see a few folks on this meeting.
So Amy says she can't join the, okay, has to jump off for a bit. Okay, no problem, Amy, thank you.
Mm.
I suppose the other thing we can do is, check in with them around that 15-minute mark, and if they need a few more minutes, we could always give them a few more minutes.
Well, and maybe the discussion is so robust that we don't ever come back. Sometimes that happens.
Yeah.
I got flustered. I saw people leaving and it popped up on my screen and I got flustered when I was doing the case study.
Mm. Which ones did you want to pop into, Melanie? 1, 2, 3.
Do we have all 5?
There's 4.
Oh, there's 4. Okay.
Yeah. So I put 10 to 11 people between the 4. It looks like some people may have left their breakout sessions. Like session 1 has 6 and there should be 10 to 11 in there. 2 has 9, 3 has 9, and 4 has 10. So.
Okay. And then breakout 1 actually has 2 of the same name.
Yeah, there's some people who joined their audio like through the phone, but are like on their computer for the screen, and so I made sure that they got assigned to the same breakout room for that.
All right. So again, Melanie, do you want to do 1 or 2 or 3 or 4?
I'll do 1 and 2.
Okay. I think the only difference between me entering and you entering is if they have clarifying questions they want about the situation or the case. I won't be able to answer that, but.
Oh, you can message me. You want to message me?
Oh, there you go. Yeah.
Okay, and you two are able to move in and out of the breakout rooms on your own, right?
I don't know. There used to be
So
a
breakout 1 says 6 of it, 6. Breakout 2, I don't see a list of people in breakout 2.
Oh, someone else is editing them.
So if you click the little arrow to expand, it should tell you who's in those breakout rooms.
Interesting. So when I hit breakout 2, it doesn't expand at all. So like, do we know that you can see people in breakout 2?
Yeah, there's 9 people in there.
Okay, interesting. I'm going to go ahead and pop in.
Oh, yeah, there's 9 and 8 and yeah.
Got it. I'll be back.
Samantha, did we say we're bringing everybody back at 3?
We said 15 minutes.
That's 3, right? Yeah.
Yeah, so it looks like we're at 7 minutes right now into the breakout session.
Okay.
Yeah.
Oh, you can see that? Oh my gosh.
Yeah, it tells me that we're at 7
That is
minutes and 45
amazing.
seconds.
What does it mean when it says 6/1 or 9/0? What is that?
Where are you seeing that?
I'm looking at the breakout sessions, how many people are in them.
Oh,
It says like 6/1 or 9/0 or 9/1.
I don't know what that is. That is different. I don't know what the 6-1 is.
Do you see what when you
yeah,
click on it? It says, yeah.
no,
don't
I
know.
see what you're talking about. I have no idea what that means. This is the first time I've ever been on the controlling end of a breakout room.
You're doing great. It's just confusing. I'm not used to WebEx.
No, but if you look down at the bottom of the WebEx screen, there's like right next to where you raise your hand, there should be one that says breakout sessions. And if you click on that, then it brings up a different little box.
Yeah, I have it.
And that's where it's like I have the timer there that says how long it's been in there, who's assigned into which breakout session, joining them. It has the button to end all the breakout sessions.
Oh, mine just has, I think because it says somebody else is editing it. So.
Oh, okay. Here, let me.
It's okay. I'm just going to join. I'm going to go into. Melissa, what? I can't hear you. You can't hear you.
Okay. Sorry. When I'm in the breakout room, it only allows me to chat with the people in the breakout room. It doesn't allow me to chat with you. But the
Oh,
question that came up is, before the patient came in, did they already have any services in the home?
no,
No. Okay.
no services. They came, they were discharged from a service because of the behavioral disturbance. They were discharged from a residential facility back to the home.
He had already been discharged from a residential facility.
Yeah.
Okay. Okay. Thank you.
Mhm.
Ready for me to bring them all back? Oh, you're on mute, so I can't hear you.
I said, well, Melanie's not back yet, so I was thinking maybe just give them 1 more minute and then we'll bring them back.
Okay. I had popped into each of the rooms and gave them a 4 and 3 minute warning
perfect.
that they were almost done. So.
Perfect. Thank you.
Mm-hmm.
Okay, I'd say probably just about any time.
Okay. Oh, now it's going to be 1 minute. So I guess it gives them a minute.
Oh, we'll just let you bring them back, huh?
Nope, not yet. Counts it down for them.
Oh, well. Couldn't hurt.
No, and then you'll have about 13 minutes left before the end of the session.
Okay. Okay.
Hello, everyone.
Hello, hello.
Some folks said they solved they figured it all out. I was very grateful
Nice.
to them.
So I think one thing we did not mention before you all went in is if we could get, maybe one representative from each of the groups to tell us, what recommendations you all would make for the team in terms of trying to move the needle when it comes to this particular case. And of course, we also encourage questions and discussion in I think we have about 13 minutes left. All right, who would like to begin? Go
One
ahead.
quick question I have.
Mm-hmm.
Hey, this is
Reed.
Bay Area Hospital Ethics Committee. We'll start off. Toward the end, we finally thought maybe there was room to look for ways to respect patient autonomy beyond just letting him do whatever he wants. And we thought that this must be something that there can be patient experience and provider experience with before. So trying to find an expert in autism, trying to find experts in narrowing down exactly what this patient's diagnosis is and looking for people who have similar kind of best practices for this type of scenario instead of trying to reinvent the wheel. Looking at possibilities of looking further at the medical indications to see if maybe there's something that we can do medically to help stabilize behavior, knowing that without that, disposition is going to be a challenge no matter what. And so maybe, some of these things like his psychiatric that are being taken as fine, maybe there's room to develop there. The fact that his medical condition is fine, maybe there's room to develop there. Looking out of house for best practices and looking for experts to consult using telemedicine, especially nowadays. We thought those were places that we could move the needle and try to change the rules of the game a little bit so we can have a better outcome.
Great.
Those
Thank you.
suggestions. Thank
Yeah,
you.
absolutely.
Anybody else?
All right, pretty soon we're going to have to start calling out groups. Let's see, Bay Area Hospital ethics team. What team were you on?
They were in one.
For which breakout
Number
room?
Number one.
Number one. Okay. Okay. How about, let's go the other end, number 4. Would someone from number 4 kind of share with us some of the highlights of your discussion and any recommendations you all came up with? All right. How about group 3?
Sorry, it took me a little bit to get the video and whatever going. So I think I was in group 4.
I could speak for 3 if you want.
Okay, sure.
We didn't come up with any answers, which I will say I was involved in this case when it was actually happening, and we didn't come up with any answers then either. So that was very cool. We came up with a lot of questions, but I think that the substantial things that we thought were, we agreed we have a lot of sympathy for the family, right? That we felt that there is not a moral responsibility to put yourself or your younger child in physical danger just because you gave birth to somebody. And that this was an untenable situation for everybody involved, including the parents, including the sibling, including the hospital, and the patient. We also felt that you know, it wasn't our sphere. I didn't feel it was my sphere, and I think people agreed. The interests of the state are not my problem. The interests of the hospital are my problem. The interests of the patient are my problem. But that those interests were not necessarily in conflict. It was clearly not in his interest to be living in the emergency department. The hospital felt quite strongly that it was also not in their interest for him to be living in the emergency department, and that so the needs of the hospital and the patient were not as misaligned as it at first might appear. The interests of the parents were maybe a little bit different, but even there they were somewhat overlapping. So nothing groundbreaking, but those were our insights.
Thanks, Lori. I see, Dr. Emery, you put in if the patient had ever expressed any wishes regarding his disposition, or if he did have reasons for his violence. We tried to figure that out, and a lot of it we noticed had to do more with the communication barrier. And so once we were able to really dig into communicating with picture charts, using some rudimentary signs, signing, that those outbursts lessened considerably during the last several weeks of his stay with us, because we did have an education team coming in to work with him, and also to work with the staff a little bit to show the ways that really helped to communicate with Gary. And so that kind of got his outburst greatly reduced. But we never really could have a communication or conversation with him about what his wishes would be towards disposition. Mm-hmm. We just mostly heard about it through what his parents wanted.
Right. Groups 2 or 3, any insight or recommendations from either of your groups?
I have no idea which group I was in, but I would say that we focused on communication needs, and it sounds like the community really pulled together and provided some great resources. My question is, what was the answer to the first one? What was the ethics committee's role in all this?
They really helped guide. They were really the true north, I'd say. And I mean, the ethics person is here with us, Dr. Morrison, but really helping, I think, guide the true north of what the question was, and maintaining, holding the patient in the center, and recognizing that this was kind of an impossible situation that we were tasked with, not just because of the patient himself having difficulties, but the idea that we were up against a resource, there were no resources for this child to go to where he would be safe, and that we would maintain the safety of family. And so one of the things that was very helpful is just continuing to focus on the best interests of the child while balancing the needs of the safety of the staff, and just continuing to be there while we had these conversations. I think it was a very robust, like you said, it was a very community oriented experience. We had several different players from organizations at the table at every meeting, and this was twice weekly. We also had the support of the school district coming and allowing their staff to come into the hospital and get them to come in. So it really was about providing the best care for this child, as we knew that we were not going to be able to just deposit him on the street. Any other questions? Does anybody want to know what happened to Gary?
Yes, please.
Yes, yes.
Gary ended up discharging to a residential treatment facility. The issue was that we were waiting for another child at that facility to be stable enough to discharge back into their environment. So we ended up providing pretty intensive services for Gary in the last month that he was inpatient. He ended up being admitted, I think, for a little over 3 months. And he ended up, I mean, towards the end, working beautifully with staff. We were able to get a lot of structure and supports in. Of course, it was still not an ideal situation for any 17-year-old to be in, but he ended up discharging to that residential treatment facility. This case happened several years ago, and for all intents and purposes that we knew, he was doing very well there. And his family was also pleased. His parents were very excited that that was the outcome, and it was kind of what they had been trying to drive through towards the whole time. So unfortunately, it was a very difficult situation, but we ended up getting the resolution that was probably the best interest for him or for them. Yay. Anything else? Questions? I guess that experience just taught me that there's never a no. That there's always a place for someone. It just takes a really long time sometimes. Any other questions? Or Dr. Morrison, did you have anything else? Not to put you on the spot, but I didn't know if there's anything else you can recall.
I don't think I have anything to add to that, except that I'm not convinced that I was the North Star, actually. If I had to describe that, I think you were. But I do think that this was a really challenging case, and but it improved us, I think, as an organization, that we came up with some organizational processes and collaborated around this specific case in ways that we used later on. And you were very instrumental in putting those processes together. And so there's other people from Peace Health at this, I see at this meeting, people that you probably don't know. You probably left before they joined, and they're still benefiting from the work that we did on this case.
Thank you. That's very kind. I appreciate that. Complex discharge planning is my big passion. So any questions? We've got like 1 minute left. I appreciate you all hanging in there.
Any ramifications for the parents? Anything in place that would discourage another family for choosing this route?
Other than us providing them a very large bill, which I don't think that they would have been able to pay back. I think it was mostly just ceremonial, to be honest with you. No, nothing. There were no ramifications. Nope.
All right. I think we're at time. Is that correct, Samantha?
Did you end up having ramifications for liability for injury to your staff?
I believe that we put in there were some changes, like Dr. Morrison said, we did some changes too in how we worked with folks that had exhibited these behavioral disturbances, but I don't think that there was ever anything that came of that, to be honest with you, for the injuries. It was just kind of, unfortunately, what people expected to have had happen when they're caring for somebody in the emergency department. I hate saying that out loud even, but no, I don't think that there was ever any liability or issues from that.
And Melanie, do you know?
The nursing staff in general were unbelievably compassionate with this patient, despite the multitude of injuries. They maintained a level of individual concern for his well-being that was really honestly moving to see.
This case was, it really was. Yes, they were absolutely wonderful. The staff was just beyond compassionate.
All right. Well, thank you all so much for joining us. Appreciate your participation, and the pleasure to have a chance to meet y'all, and take care and enjoy the rest of the conference.